All right. So, welcome. Good afternoon. For those of you that are in the great state of Wisconsin, it's a beautiful day out. So, I appreciate you joining us because I know I can't wait to get some fresh air. But my name is Angela Kowalski. I'm our enrollment program manager. So, I work with students as they are getting to our school. And I have the pleasure of being in charge of our dual degree early assurance program as well. So a few of your names look very familiar, so I'm glad you guys made it. But I am not the one that's going to be the star of the show today. We have four outstanding instructors that are going to be sharing with you their backgrounds and what they're doing currently in the field of pharmacy. So with that being said, we're going to have Dr. Hovis start things off. Dr. Hovis, if you are sharing a PowerPoint, feel free to share that. You should have no problems. If not, no big deal. But I'll go ahead and let you introduce yourselves and take it away.
Sounds good. Thanks, Angela. I was going back and forth about whether to do a PowerPoint or not, but I think ultimately I'm not going to do a PowerPoint because I'd rather keep it more conversational and less me presenting. And yeah, also want to have a level playing field. I figure with four of us presenting, I don't want to hog the spotlight too much. But hello, students. My name is Dr. Hovis. It's called a clinical pharmacist. So I practice in the ambulatory care setting, which has nothing to do with the ambulances. It is in an outpatient clinic. So like presumably you have a primary care physician, you go to clinic to see that primary care physician. So that's where ambulatory care pharmacists practice. I am clinical faculty, so I practice 2 days a week there, and then the other 3 days a week are at MCW, where I course direct our population health course and our advanced cardiovascular course. So that's where you'll interact with me mostly in the curriculum. But in clinical practice, I think that's what I want to focus on today. And really, I think is the purpose of this meeting is to kind of illuminate some of the different career paths that you would have the opportunity to explore if you enter pharmacy school, and just to kind of get a better idea of what do you do with a PharmD degree. So I think most people, and if I were to ask you to, kind of raise your hand or tell me what you think a pharmacist did, I think most of you would have a vision of a retail pharmacist who works in, big retail chain like CVS or Walgreens. That's probably where you've interacted with pharmacists in the past, unless you have some other pharmacy experience. But generally, that's what the lay public thinks of. And traditionally, that has been the largest employer or employment sector for pharmacists, right? They have the most pharmacist jobs to offer, particularly new graduates. But we're in a healthcare industry that's rapidly evolving and has been evolving quite a bit in the last 20 years or so, especially. I'll say really the Affordable Care Act that was passed in 2010 really kind of started to expedite this evolution away from, in the pharmacy profession, us being tied to a particular product. So mostly pharmacists would, you'd like check a prescription and then you dispense the prescription, and the money was made basically by, it's like any retail setting, the pharmacy purchases the medication for cheaper than they sell it for. And they have a fee for professional counseling from the pharmacist, but also just dispensing of the medication. But that sector of pharmacy practice is really kind of shrinking. I wouldn't say so rapidly, but it used to comprise the majority of pharmacists in terms of the jobs that they would inhabit after graduation. But now it's, I think the statistics that I saw, one of my colleagues, Dr. Al-Alfi, speak about, who I see is maybe just entering now, but she shared some statistics that's about 40% of the workforce now is this retail pharmacy. One of the fastest growing areas of pharmacy practice is this idea of clinical pharmacy practice, which encompasses a wide variety of different, I'll say pharmacy specialties, but I'll focus on ambulatory care, which is rapidly growing, right? So this is where pharmacists are embedded in primary care clinics to work with primary care teams to try to improve the quality of care that's provided for patients, to try to improve the patient experience of care. So like, are you satisfied? Do you enjoy the experience of going to your physician or going to your family practice? Is that something that's like not a dreadful experience for you? And then can you do this for a lower per capita cost, right? So we've seen some of you, if you have experience in healthcare, maybe you've heard this in the news, that are the percent of spending that we as a nation spend on healthcare relative to our GDP is much higher than other industrialized nations, but our outcomes, how well we perform on various outcomes, is not, we're really not in the top position or even sniffing the top 10, which is kind of embarrassing as a nation. So we're trying to figure out how to address that. And pharmacists, turns out, can actually play a pretty crucial role as part of a broader healthcare team to try to improve some of those outcomes. So that's kind of what I've staked my clinical career on. That's what I try to inspire students to think about in their own careers, is how do they achieve those outcomes, better health outcomes for the patients, a better experience for the patients, and doing it for a lower per capita cost. So in my clinical practice, I've been at MCW for about 5 years now, and I practice at Freighter, which is our partnered clinical or clinic institution, which technically I think we're under the same umbrella, although in the weeds we're maybe two separate entities, but that is a whole different conversation. But I practice at Freighter, and I helped start the digital care monitoring program, it's called, where we contract or partner with a vendor that allows us to interact with patients via text message for them to send us home blood pressure readings from a cuff that we actually send out cuffs to patients, but then they also can purchase cuffs on their own. So they would take their blood pressure from the comfort of their home. They would respond to our text message, which we send twice a week, and tell us what their blood pressure is. And then our vendor helps us to risk stratify patients into different groups based on a rolling average of their blood pressure. And then I, as the pharmacist, partner with their primary care physician to work under what's called a collaborative practice agreement, which is it enables pharmacists to make medication adjustments to basically help better control their hypertension. I see Dr. Lord just shared a link to a publication that we had last year, or actually it was the end of 2024. So I suppose technically 2 years ago now, but that talks a lot more about the program in detail. So if you're interested, feel free to read that. But basically then we're able to make medication adjustments and get patients to their goal blood pressure faster than if they just go through the usual care model, which is where really the physician's kind of at the center and they're doing everything. They're making medication adjustments. And physicians have a ton on their plate. Not to say that they do a bad job at this. They don't. They just have a lot of competing priorities and expectations for them. So this team-based care, this team-based model where the pharmacist helps in chronic disease management to manage blood pressure has been shown to be very effective across several different studies. So that's the work I'm doing at MCW. And I would say this is really one of the biggest opportunities for, I'll say, like your generation of future pharmacists, is to figure out how do you use the skill set of a pharmacist to improve patient care, improve the efficiency, the experience, right? All these things I've been talking about. And I find students often have really awesome ideas for how to do that, about areas that they're passionate about. And again, that's kind of where what I try to challenge students to do in the curriculum is to think about how they might use their own knowledge, skills, and abilities in our curriculum, and then post-graduation in order to achieve those goals. I will stop because I've been talking a lot, and I will pass this over. Angela, help me out. Who do you want to
Yeah, we
present
got,
next?
well, first off, are there any questions for Dr. Hovis? And we'll leave some time to at the end.
Yeah, I'll stick around. So if you're percolating on a question, feel free to type it in the chat, or
Yep,
I will stick around. So just ask it at the end too, if that's easier for you. But thanks for listening to
perfect.
my spiel, and
Yeah.
Angela, I'll let you popcorn it to the next
Yes,
faculty.
Dr. Lore, you are next up. Thank you.
Right. I have a brief presentation. Hold on a minute.
We can see it. Thank you.
Good. All right. So I'll just be sharing my journey and to academia pharmacy. I won't share too much about ambulatory care since Dr. Hovis already mentioned a lot of the details around ambulatory care. And then just a little background about me. So when I was in elementary school, I wanted to be a teacher, and then I wanted to be an architect, and then a graphic designer. And then I was exposed to pharmacy when my uncle introduced me to his pharmacy team at a dinner. And the pharmacist there said, if you're good at math and science, this might be a good place for you. And so that's how I got introduced to pharmacy in my junior year in high school. And then I started to plan to get into pharmacy school. Then I went to UW-Madison because it was the only school that was in Wisconsin, and then graduated from UW-Madison, actually thinking I was going to be an ambulatory care pharmacist. And then in residency, I learned that I was also pretty good at clinical precepting with students, then got exposed to academia there, getting a teaching certificate program, participant in the residency in Minnesota. And then that's how I kind of grew and joined in academia for my first position. So what I will say is your journey will change and ebb and flow. You never know where you're going to end up. That there's many different areas of pharmacy that you could potentially be a part of. And even now, I think about the different avenues of pharmacy, whether you become industry, fellowship, there's just different ways of utilizing the strengths of where you want to end up in the future. And what I'll say is right now, the graphic design, it happens within my research. Architecture, I was able to build a house. A teacher, I'm an educator now for student pharmacists, which is kind of crazy about those things that you thought you were going to do when you were younger and how it impacts like what you currently do too as an academia pharmacist. So in academia pharmacy, there are four major pillars of academia. There's educator, being a scholar in education, having that clinical practice, and then leadership and service are the four tenets of academia pharmacy. And so as an educator, these are kind of the things that I teach. So I'm actually a course director with Dr. Pape for the FAR 560 Self-Care and Wellness course. We talk about wellness and self-care, as well as whole health and the dimensions of whole health. Have students do a personal health assignment to evaluate, how often do they sleep, exercise, healthy eating. And then culminates at the end with a review of like complementary integrative medicine with the culture box assignment, where you review your own identities and how it impacts your views of health and the healthcare system. I also have a lot of initiatives around health advancement for Asian Pacific Islanders through education, teach a lot of the cultural humility topics that are throughout the curriculum, mostly focusing with refugee communities and how language transcends barriers for patients. And then I also teach the medical Spanish elective course, as well as launching the specialty pharmacy elective course. And specialty pharmacy is a new area of pharmacy where you could learn about high cost medications. It's a mix of ambulatory care, I would say, and community pharmacy, where you do more consults and you're a part of the care team in access to medications for these high cost medications. And so it is a rising area of pharmacy is this specialty pharmacy potential training as well. And then this past year, I actually was able to teach biostatistics again. It's been a while since I taught statistics and evidence-based practice. And I think learning the skills of evidence-based practice and mastering them in journal club, becoming like a journal club guru, it has helped with your role as in the clinical practice setting as well. So I do serve as the administrative lead for the research committee, as well as our research and scholarship forum that we host annually at MCW. Okay, so education was the first pillar of academia, now scholarship. So my work in community engagement is around building health equity with communities, fostering trust and collaboration, and collaborating with various community organizations here in Milwaukee as well as in Madison. My first exposure to community engaged research was actually with this project called the Prevention of Opioid Misuse through Peer Training. And we collaborated with Dry Hooch, which is a peer trainer for veteran communities, and provided education around access to services to assist peer trainers with opioid addiction and connecting veterans with other veterans to really advance the health for patients. And then I pivoted from veteran communities to refugee communities. I am Hmong refugee, come from a Hmong refugee family as well. And so started to work with a bunch of different organizations from the Hmong Institute all the way to Nyajong Milwaukee TV, have done a lot of work around building health, training people to learn about Hmong refugee communities, and then helping with refugee health within the medical school curriculum as well. And then this is just a photo of the Robert Wood Johnson Foundation Clinical Scholars Program, which is a program to train and build health equity leaders across the nation. And I was one of 4 pharmacists in the nation that completed this training program. And then the last little pillar of like the scholarship piece is scholarship of teaching and learning. So anywhere that you're teaching in the curriculum, you could also potentially do a potential study around it as well. So I've done work around empathy, reviewing students' success, and novel ways of teaching in the classroom to engage students in the classroom as well. Okay. So practice site is the next pillar of academia. My work is mainly in ambulatory care, providing holistic pharmacotherapy services for mainly Spanish-speaking communities and Hmong refugee communities. So pharmacists do play a critical role, and the disease states that I oversee are diabetes, high blood pressure, high cholesterol. I've done work around vaccinations. We were a part of the COVID vaccine clinic that was a part of MCW, vaccinated there as well as a bunch of other chronic diseases. And so much of my time in the clinic setting is meeting with patients who have more than 20 medications, reviewing their medications to make sure that they're indicated, they're efficacious, they're safe for patients, ensuring they're adherent to medications. And I think of my butterfly patient. So like drawing a butterfly for the patient's medication for their thyroid to ensure that they're adherent for their medication. So those are kind of the areas that I've been in the ambulatory care setting, is mainly in federally qualified healthcare centers serving underserved Spanish-speaking communities. Okay. And then if you want to become an ambulatory care pharmacist, when you join and become in pharmacy school, then afterwards you would do a residency, PGY1, and then the PGY2 residency, and then ultimately obtain board certification in ambulatory care. So after our names, you see those letters BCACP. Those are board certifications in specific areas of pharmacy. And then I do work a lot around bridging language barriers, ensuring patients understand their medications. This is just an example list of medications that I create that has the sun, the moon, the stars, just so that they know when to take their medications and what they're using medications for. I usually label each medication. So yellows in the morning, blues at night, greens in the middle of the day, red is as needed, to really ensure patients understand their medications and medication use. And so this is just an overview of what type of care that's provided in the ambulatory care setting. And we do document every visit as well. Okay. And then in leadership and service, I'm currently serving as the founding chair for the Clinical Sciences Department. We have 30 faculty in the School of Pharmacy and 25 are in the Clinical Sciences Department. So those are practicing pharmacists as well as social administrative pharmacists. And then these are just some programs that MCW offers at MCW. And so wanted to share that these are potential areas when you're a resident that you could potentially be a part of, whether it be the teaching certificate program, learning about academia pharmacy, the research certificate program to build skills in research. I also serve as the director for the fellowship. So this is for someone that might be interested in academia pharmacy to really expand in their growth and in all the 4 pillars that we're talking about today. And then I'm also the residency site coordinator for Walgreens and MCW. They have a specialty pharmacy community-based residency program. All right. And this last part is just supporting and inclusion of women. And that's just something that I've been always very passionate about. All right. Now opening the floor to any questions. Otherwise, popcorn over to the next person.
Thank you, Dr. Lore. Are there any questions out there? Again, feel free to put them in the chat as well. And if you think of anything, that's totally fine too. All right, next up, we have Dr. Shannon.
All right, can you hear me?
Yes, thank you
Okay,
so
great.
much.
Yeah. All right, my name's Dr. Eileen Shannon. I'm a pharmacist at Froedtert Hospital in the medical ICU, and I'm one of our partner clinical faculty at MCW. So I teach mostly in the spring during the students' final session before they go out on rotations. I teach critical care topics. But I want to focus mostly on what does kind of a hospital pharmacist do, because we haven't really touched on that yet. So when I was thinking about pharmacy school, and once I was enrolled in pharmacy school, kind of my biggest, or I knew that there were outpatient pharmacists or like community pharmacists, you know, who work at Walgreens and CVS. And I knew there were pharmacists in hospitals, but I didn't really know much beyond that. And I had an inkling that I wanted to be a hospital pharmacist. But again, my exposure to that side of pharmacy was pretty limited. And it really wasn't until my internship at the Madison VA in between my second and third year that I was exposed to kind of all the different areas that you can specialize in as a hospital pharmacist or like an inpatient clinical pharmacist. And during that internship, I was exposed to an ICU pharmacist or a pharmacist that works primarily in the critical care areas in the hospital or the intensive care unit. And I only spent 3 days with that pharmacist, but that was enough to convince me that this is what I want to do. I want to be an ICU pharmacist. And what I really loved was that this pharmacist went on rounds, daily rounds with the care team. So he was rounding with the attending physicians. The care team relied on him to answer questions. He knew everything about his patients from a medication perspective. And when he wasn't on rounds, he sat in the unit, in the ICU. So he was so accessible to the nurses and to the care team throughout the day. They would just come up to him and ask questions. So I saw that he was a very valuable member of the team, and he was so knowledgeable and integrated into the team, and he impacted patient care on a daily basis. And I just was in awe of that. I was like, this is what I want to do. I want to be an ICU pharmacist. So currently I work in the medical ICU at Froedtert. There's many different types of ICUs at Froedtert because we're a larger institution. But I want to talk a little bit about the pathway to get there, and then also what I do on a daily basis. So once I decided that I wanted to be an ICU pharmacist, I knew that I had to pursue a residency after pharmacy school. Now, not every ICU pharmacist needs to do a residency in order to end up in an ICU, but I knew I wanted to work at a large academic medical center, level 1 trauma center, and typically to be competitive for those types of jobs, you need to do a residency. So after I finished pharmacy school, I did a PGY1 year of residency at UW. So a PGY1 is kind of like it's a year of residency where you have rotations all over the hospital. So you just get this broad exposure to all different types of inpatient care. So I did rotations in transplant, in oncology, in general medicine, and surgery, in the emergency department, and the ICU. So again, you get this really broad overview of all the different types of care within a hospital. And then I stayed on for a second year, a PGY2. And in that second year of residency, that's where I specialized in critical care. So all of my rotations during my second year of residency all of those were in an ICU, so a different ICU. So cardiovascular ICU, neuro ICU, pediatric ICU, medical ICU, trauma ICU, our burn unit. I did a shortened rotation at the toxicology center here in Milwaukee. But again, so I specialized for an entire year to learn how to be an ICU pharmacist. And then after that, I was able to take any job really anywhere in any type of ICU. And I eventually worked my way. I worked at a couple different places, but ended up back at Freighter, and now I work in the medical ICU. So what does my day-to-day job look like there? The number one thing that a hospital pharmacist spends their time doing is order verification. So any order, any medication order that a physician enters for a patient in the hospital, whether it's a blood pressure medication or an antibiotic or a medication of something that they take at home, the physician enters that order and a pharmacist has to verify it. So we are the double check. So when I'm verifying orders, I'm looking at a lot of different things. I'm looking at, why are they ordering this medication for this patient? Does it make sense? Is the dose correct? And when I'm thinking about the dose, I'm thinking about the patient's age, their kidney function, their liver function. I'm thinking about the route of the medication. Are we giving it orally? Do they have a feeding tube? Are we giving it IV or intramuscular? Making sure all of those are correct. I'm also looking at drug interactions. When a patient's in the hospital, they're on so many different types of medications, and we need to make sure that they're not interacting with one another in a harmful way. We're also there to optimize medication. So maybe a patient came in with an infection and we started them on really broad spectrum antibiotics. Well, maybe now a couple of days later, we have culture data and we can narrow those antibiotics or change to an oral option. The pharmacist plays a huge role in optimizing medications, making sure that we have the right medication for the patient's condition. I'm also always thinking about, what is a patient on normally at home? And do we have those medications ordered here in the hospital? Is it still appropriate that they're getting those medications? Maybe we need to hold some of those medications. Maybe we need to change the dose. Or maybe we were holding some of their home medications and now we have to get those restarted. So we call that medication reconciliation. As an ICU pharmacist at Freighter, we are also part of the code response team, which means when a patient has a medical emergency in the hospital, meaning or a cardiac arrest when their heart stops, there's a code response team, and one of the ICU pharmacists is part of that code response team. So we carry a pager, and if that pager goes off, we get ourselves to that wherever the room is where the patient is experiencing that emergency, and we come with a backpack full of our code medications, and we help provide medication support for that emergency situation. In addition to order verification and code response, we also are a huge resource on the unit for our nurses if they have questions about medications. We're a huge resource for our physician counterparts. At Freighter, we are a teaching hospital, so we have medical residents and medical students and physician fellows constantly rotating through all of the different units. And a lot of times they look to the pharmacist as a resource for ordering medications for their patient, optimizing medications, keeping their patients safe. We also, at Freighter, the pharmacist has a huge role in obtaining medication histories. So going and talking to the patient, figuring out what medications they're on normally at home and making sure those are restarted if appropriate. And then on the back end, when a patient's leaving the hospital, we have a big role in discharge. We make sure that the medications being ordered on discharge are correct. We make sure that refills are being sent to the correct pharmacy. And then we actually go to the bedside and provide discharge education on all of the new or changes to the patient's medication regimen. A big part of why I love my job in the medical ICU is that I get to be present for rounds every day on our patients. So I have a list of patients that I'm covering for that day. Before rounds, I'm reviewing those patients, coming up with anything I want to bring up on rounds. And then on rounds, it's usually an attending physician, a physician fellow, medical residents, medical students. The bedside nurse will be present on rounds, sometimes the respiratory therapist, and the pharmacist, the unit pharmacist. And because we're present on rounds, we can be really proactive about making interventions to the medication regimen for the team. And again, we just are there also as a resource. If they have any questions about anything, we can help answer questions and triage problems. You become a very big problem solver when you work on the inpatient side. I want to see if there's anything else I wanted to say. I think I talked about everything. So if anyone has any questions, I'm happy to answer questions. Otherwise, I'll flip it over to Dr. Stanton.
Thank you, Dr. Shannon. I actually have a question. These rounds, how many patients do you typically see and how long do the rounds take?
Yes, that's a great question. It varies quite a bit. I would say the smallest number of patients I've had on a team would be maybe be seven, and the most is probably in the mid 20s, like 25. And so the time of rounds definitely depends on how many patients are on your team, but also depends on the attending that you're working with and kind of the pace that they like to go at. I would say rounds are anywhere from an hour to 4.5 hours every day.
Yeah, it definitely varies. That's
Yes,
great.
yeah. Mhm.
Any other questions from the audience? All right. Well, thank you so much. We will now have Dr. Stanton go ahead and take us home.
Everyone, my name is Matt Stanton. I'm one of the clinical associate faculty in the School of Pharmacy. I mostly teach in the second year of the program in a variety of topics pertaining to emergency medicine and toxicology, and I help course direct the critical care toxicology substance use course, which is one of the last courses you take before you go out on your advanced pharmacy practice experiences. But my clinical sites include the emergency department at Frederick Hospital. I've been at Frederick Hospital for 16 years now. I have most of that time has been in emergency medicine. I did my pharmacy school at Midwestern University in Glendale, Arizona, which is actually another 3-year program that Dean McKinnon founded. So I'm well familiar with how intense our curriculum is, since it is fairly similar to that curriculum. I'm also one of the clinical toxicologists at the Wisconsin Poison Center, which is on campus here, and I have been at the Poison Center for 12 years now. So my work in emergency medicine, I got involved. Well, I got interested in it actually on my introductory pharmacy practice rotations, where I was able to go to an academic medical center. I got to spend some time with the pharmacist there in the emergency department, and even though it was only for a few days, it was a great experience, and I continued wanting to work there. Along the way, I also had a clinical toxicology elective at our school, and during my API year, I was able to spend some time at the Poison Center out in Phoenix, Arizona. So that was kind of where my interest really came into emergency medicine. If you think you have this idea of what you want to do when you start school, my first or my only experience before starting school was in a independent chain pharmacy back in my hometown. So when I went to pharmacy school, that's really what I wanted to do. And then I started working at a hospital out in Arizona, and I was able to. It kind of shifted my thought process of where I wanted to go. So just because you pick something when you come in, you might change your mind as time goes, and that's perfectly fine. In emergency medicine, one of the reasons I like it is because you get to see a lot of different patients, and you get to help a lot of different people in a variety of different ways. You think about all of the patients that come into the emergency department. We usually, on average, see about 200 to 230 a day in a 24-hour period. Not all of them get admitted to the hospital. Actually, only 30% of them get admitted to the hospital. So 70% of the patients that come into the emergency department actually end up going home. And not all of them need a pharmacist to be involved with their care. Generally, it's some of the more medically complex patients. It could be patients with critical illness, and we are the level 1 trauma center, adult level 1 trauma center for the area. So we also attend trauma care, and that could be presented in a variety of areas, such as motor vehicle collisions, gunshots, penetrating trauma from stabbings or other foreign objects. So there's a lot of different. It's a vast, diverse patient population. We also help out with people having strokes, people having heart attacks, people having eye emergencies. We do get patients that come in that, have uncontrolled blood pressure, and how do you handle that? Do they have to get admitted to the hospital? Do we have to adjust some medicines for them to go home? Do they just need to make sure they follow up after they leave the emergency department? So it's really a really a great area to keep up a lot of my skills and allow me to stay on my toes, so to speak. We take API students and IPI students in the emergency department, and we expose them to a lot of different things that we get exposed to. We have patients with diabetes that need insulin adjustments. Some patients end up in diabetic ketoacidosis that we have to help out with dosing for certain medicines there. We have patients that have injuries that need just some anti-anxiety medicine, so we can help maybe reset a joint or reset a bone. So we're there for a lot of dosing, a lot of drug information questions. We do a lot of antibiotic dosing for a lot of patients that come in, because that could be a way for patients to get admitted to the hospital, but sometimes patients just get antibiotics and go home. So really, it's something that allows me to practice in a lot of just general areas that I like to practice in. We also have a residency program, a PGY2 residency program, which for the most part, like was mentioned previously, you might not need all the time, depending where you want to practice, but a lot of larger medical centers might like you to have that type of training if you want to go that route. But usually some postgraduate training is helpful regardless. As far as the toxicology portion of what I do, the Poison Center is one of 53 poison centers in the United States. Our area covers the area of Wisconsin, so we're responsible for anyone that calls our poison center from Wisconsin, and all poison centers are linked through the area code that you call from. So if you have a Wisconsin area code on your phone and you're down in Florida and you call the Poison Center 1-800 number, you're going to get the Wisconsin Poison Center, and we may or may not be able to help you depending on what's occurring. When you call that number, you talk to, after you get through some of the pre-recorded messages, you talk to a human. Those humans can be a pharmacist, a nurse, or even a physician or a physician assistant. Every poison center is slightly different as far as who staffs those phones. It could be some places have all pharmacists, some places have all nurses, some places have mixes of nurses and pharmacists and physicians. It really just kind of depends where they're located and where they're funded through. Those people that staff the phones are called specialists in poison information, or SPIs. So we call them spies, not SPY spy, just SPI spy. And they're well trained in toxicology. I am responsible for their education, and I help direct a lot of their education and give them resources and keep them updated on different toxicology happenings that are occurring. The other route you can go is to get board certified in clinical toxicology, and that's through the American Board of Applied Toxicology, which is the non-physician and non-veterinarian board for certifying toxicologists. And if you have that, you're still able to work the phones at the Poison Center, but you're also able to do several other administrative type duties. And all poison centers have to go through an accreditation process, and most of the time they need a clinical toxicologist to be a part of that process in order to fulfill accreditation. We also take a number of different learners, from physicians, student physicians, fellows, residents. We take pharmacy students, pharmacy residents, and we really have a real interdisciplinary group that we get to bounce cases off of. And we take psychiatry residents, and we take internal medicine residents, pediatric residents. So everyone really gets to use a lot of their knowledge and apply it to a lot of the cases that we end up seeing. And we we talk about a lot of the cases that we get called about from other places in the country. We also have a medical toxicology fellowship that we go and see patients at the bedside at Children's and Froedtert Hospital. So we we also have an outpatient clinic actually that we will have patients come into the outpatient clinic twice a month. So again, really a lot of different areas. The reason I like toxicology is, again, it is a staunch generalist view of a lot of different things you need to know. So not only do you need to know pharmacy and the pharmaceuticals aspects, which we get trained on, you also have to know environmental exposures such as lead, envenomations from either snakes or spiders. You have to know other substances and chemicals like antifreeze and windshield washer fluid and potential gases like cyanide, hydrogen sulfide, carbon monoxide. So there's again like this endless array of patients that can get exposed to several different things. And ideally, we want to keep people out of the hospital, which is why they call the poison center, but sometimes they have to go into the hospital for whatever reason they have. So we're a resource for the state, and it's a really satisfying part of my job. You can get fellowship trained as a pharmacist through several fellowships throughout the country, but it really depends on the model they have and what type of exposure they can give you. And sometimes it's not always routine that they have positions in a lot of places. So there's only maybe 6 or 7 fellowships in the country to choose from right now. But it's a way to get board certified if you want to go that route. But I didn't realize, even going through school, that pharmacists can work at poison centers. So this is just one of the ways I try to get students interested in a lot of things. And not all toxicology trained pharmacists actually work at poison centers. Some work in emergency medicine, some work in critical care areas, some work in industry. It just depends what you want to do. I don't think I have much else, unless anyone has questions or comments or thoughts about anything.
Yeah, thank you. Any questions out there? I am curious, what's the craziest call you've ever gotten?
One thing I have learned over all of my years is you never say never and you never say always. So coming from Arizona, well, training out in Arizona, I would always think, oh, Wisconsin, I would never see a scorpion envenomation, because we saw a lot of scorpion venomations out in Arizona, obviously. But sure enough, we had someone that a scorpion took a trip from a box of bananas down in South America and made it to the Milwaukee area. So we handled a scorpion envenomation, which I never thought I would see up here, but we did. Yeah, there's there's a lot of unfortunate stories with people mixing up certain chemicals for things, and most of the time it doesn't lead to anything too terrible, but it's unfortunate and annoying, more or less, if you mix up something that is not supposed to be super glue with super glue, and you unintentionally glue something that is not supposed to be glued to something. There's plenty of those stories that occur.
That I believe. Awesome. All right. Looks like we do have a question, so thank you for that. And it says, how do you choose a residency and or fellowship, or whatever, or whether to do one at all? Sorry, there was something in the way. So whoever would like to take that, feel free.
I can speak to it a little bit. Because I decided that I wanted to work in a specialized area like critical care, and because I knew where I wanted to work, like a level one trauma center or a large academic medical center, I knew that I would be most competitive for those jobs if I did both a PGY1 followed by a PGY2 in critical care. So kind of my desire for where I wanted to end up is what prompted me to want to do a residency. But I think even if I hadn't had that desire to work in critical care, even if I just wanted to be a hospital pharmacist, I think I would have pursued residency anyways, because you learn so much during your residency year. And so whenever I'm working with learners and if they're kind of on the fence, I say, as long as you can afford to be a resident, because that is the downside of residency. You make about a third of what a pharmacist would make, and you work about 3 times the amount as a pharmacist makes. So as long as you can manage that financially, if your current circumstances allow for that, I always say like you'll never regret more training and more learning. I don't have as much experience with fellowships, but I imagine it's probably a similar thought process there. Um, and then as far as deciding which residency to do, that's like a whole nother topic, or like there's a whole matching process with residencies and stuff. So there's an interview process. You can usually tour residencies, and for me a big one of the big factors for me choosing where to go for PGY1 is that I wanted to stay at the same institution for my second year of pharmacy. So I was only looking at programs that offered both a PGY1 and a PGY2 in critical care. So those were some of the deciding factors for me. Matt, I don't know if you have other thoughts, or Dr. Hovis and Dr. Lore.
I could speak to fellowships as well, since I'm the director for the Academia Pharmacy Fellowship. Most fellowships across the nation are more drug industry or research-based types of fellowships. So becoming like a medical science liaison for a drug on the drug industry side, those are the typical fellowships that you will potentially see. MCW is one of probably 10 to 15 programs in the nation that has an academia pharmacy fellowship with the goal of becoming a faculty in the future. Though we have had some fellows become clinical pharmacists, some fellows that decided to go back to in ambulatory care or any type of practice site that they were most interested in. And so at the end of the day, you want to think about, where do I want to be? Do I want to, and what do I like to do? I think that's where's my passion? And I think that could help in tailoring if you would pursue a fellowship or a residency. Um, I think for me, when I was in pharmacy school, only 10% of my class was pursuing residency at that time. And I'm getting at the second question about how hard it is. Now it's a lot more competitive, I would say. Probably 50% of the class or cohort are applying for residencies and fellowships. So there has been a change and like a shift from when I graduated, that was 10% of my class, and now it's like half of the class or even more that are applying for residency or fellowship. And what I will say though is your rotations help. So with MCW School of Pharmacy, you have several experiences for your introductory pharmacy practice experiences. At other schools and other places, they might have only 2 weeks, that you get an exposure to these IPI experiences. And each rotation experience is like an interview because you do learn about there was an alumni that told me I think they were exposed to it on their IPI and then they had an API. Advanced practice experience, and then they actually got a job there. So you never know like where that will end up and what you will decide to do in the end, but being open to potential ideas of where you would like to end up would be helpful. And then PGY1, PGY2, postgraduate year one, there's a lot of alphabet soup in pharmacy world. So postgraduate year one is the first year of residency, and then PGY2 is postgraduate year two, which is more of an advanced role. So it could be critical care, emergency medicine, oncology. And so it really depends on where do you see yourself in practice. Or like me, I didn't know what I was doing in pharmacy school. I think I chose to go to my residency was in Minnesota. University of Minnesota is really well known for ambulatory care. And so that's why I decided to pursue that residency because they were PGY1s with ambulatory care emphasis. So there's different types of residencies that you could potentially look at as well. Yeah.
Yes, thank you. I wanted to add in there, can someone explain IPI and API rotations? Because you guys talked a lot about that, but these students might not quite understand what IPI stands for and API stands for. So if somebody wouldn't mind doing that.
Sure, I can chime in. So IPI is your intermediate pharmacy practice experience, and API is your advanced pharmacy practice experience. Basically, these are opportunities for you during your time in pharmacy school to go on rotations, spending time with practicing pharmacists in a variety of different fields. There are sort of required rotations for all pharmacy students to complete, but then you also get the opportunity to do different elective rotations with, usually it's with partnerships that we as MCW have set up, but I think there are opportunities if you have somebody that you know of, like a family friend or something that you're really interested in, you have the opportunity, I think, to forge a new partnership if you can work with our Office of Experiential Education to set that up. But basically, our IPI rotations start, is it session 2 or session 3?
Session 2. So within 12 weeks, students are out there.
Yeah, so I think that's one unique aspect of our program is we're on the earlier side in terms of getting our students kind of boots on the ground, spending time with practicing pharmacists. I know you get the opportunity to immunize pretty quickly, given that you start in the summer and then we try to get you trained and ready for the start of flu season so you can really make an impact your first year with us. And then your API rotation, I should say you do your API rotations during your first and your second year. And then your third year with us would be all API rotations, where again, you go on these required rotation blocks, but then you have some electives and they're 6-week blocks. So you spend 6 weeks full time in different practice settings, really getting your boots on the ground and developing, I won't say an expertise, but like really getting a flavor of what it's like to be a pharmacist in that particular practice setting. And I think that's where probably is most helpful for you to help decide what ultimately it is you want to do. And this was a point I was going to make, which I think Dr. Lohr had mentioned, but I just want to make like crystal clear. The decision to do a residency or a fellowship, most people don't really decide that until your third and final year with us. If you're doing a 4-year program, it would be a 4th year, but like usually you can wait until your happy year to really decide definitively if you want to do that or not. Because a lot of times it is it are those clinical experiences that will sway you to say, you know what, I had an amazing time on my ICU rotation with Dr. Shannon, and like that's what I want to do. And she says it's a good idea to do a residency, so that's what I'm going to do. So that's usually how that ends up.
Thank you. Any other? Oh, go ahead,
Well,
Dr. Shannon.
sorry. Well, just to piggyback off what the residency talk before, I think sometimes, we talk about doing postgraduate training or I guess fellowships too. Even if you don't really know what you want to do, or if you find everything interesting, I think that's honestly a good opportunity to pursue some postgraduate training too. Yeah, at least I can't speak to the fellowship exactly like Dr. Lohr can, but from the PGY1 residency training, you get a lot of different experiences in a lot of different areas. So it's basically kind of extending your appy you're just at one place, and maybe you have a better idea of what you want to do after that. And I think you should use all those learning experiences as things like you want to do or maybe are more interested in, and it's still good to know what you probably don't want to do as well, right?
And then I think I would also add it allows you the flexibility to pivot. If you have a residency or fellowship, I have a colleague of mine, we graduated the same year. They're 10 years out, pharmacy background. So likely, like the requirement states PGY2 or PGY1 resident. And I do think that it gives you flexibility of where you potentially could go. And if you don't have the residency training, it doesn't mean that you wouldn't be able to get the job because sometimes it is years of experience, but it has that specialty kind of area that allows you more for flexibility if you.
Awesome. Any other questions from the audience? All right. Well, we definitely want to thank you for taking time out of your day. To our four wonderful clinical faculty members, you guys are amazing. And all the students that showed up as well. Thank you so much. Dr. Laura, thanks for putting all that information in the chat box. She put a lot of great stuff in there. The first one, pharmacyforme.org, is a wonderful website that you can go on and kind of like do an inventory on what interests you, and it will kind of shoot some different things out as far as job opportunities in pharmacy. So some things that you'll learn about that you probably never thought of before. So, yes, thank you everyone for joining. I will stick around for a few more minutes if anyone has questions. Otherwise, you are welcome to take off. Thank you.
Thanks. Good luck.
Good luck to you all.
Zane, I will put that website on here again. I know you came a little late, which is totally fine, but we want to make sure you get it.
I have a question.
Yes.
Uh, where where can I find the recording for this meeting?
Yes, so that's a great question. In fact, I'm going to stop recording. We will